Well, I was born in Pakistan and got settled in Iran. Went to UK, Canada for fellowship in neuroanesthesia and neurocritical care. And I worked as a faculty member in Tehran University of Medical Sciences, where I was a full professor. And at the same time, I had to look after the residents and fellows of neuroanesthesia and neurocritical care, which was under my supervision. It was a year back that I got retired after serving for 35 years as a faculty member. And then after 2 months, my wife passed away. And that gave me a great shock. And as I said, it devastated my soul and body. And presently I'm with my children. I'm the chief editor of Archives of Neuroanesthesia, Archives of Anesthesia and Critical Care. I was the guest editor of Anesthesia and Analgesia, American journal, the oldest journal, I believe. At that time, Professor Schaefer was the chief editor. And we worked nicely. And during this time, I've attended many international congresses, symposiums. And as I was even invited as an examiner to Philippines for the postgraduate examination. We were 3 in number. One was from Australia, one was from I think Canada, and the third was myself. So I've traveled along a lot and learned a lot from others. I'm a small fry. Whatever I could do, I've done. And now I am 71 years of age and looking after my 2 daughters and 1 grandson. Most common peripheral neuropathic disorders in pregnancy with a focus on clinical recognition, diagnosis, and treatment. Recent findings in literature suggest some case reports, case series, and retrospective studies, but there are hardly any prospective studies available. Recent work, particularly in carpal tunnel syndrome, brachial neuritis, and inherited neuropathies in pregnancy, has added to our knowledge of this field. Awareness of diabetic polyneuropathy with associated autonomic dysfunction in pregnancy has grown as the incidence of diabetes mellitus increases in women of childbearing age. Women may develop mononeuropathy, plexopathy, radiculopathy, or polyneuropathy during pregnancy or in the postpartum period. Pregnancy often influences consideration of etiology, treatment, and prognosis. In women of childbearing age with known acquired or genetic neuromuscular disorders, pregnancy should be anticipated and appropriate counseling provided. An interdisciplinary approach with other medical specialties is often required and necessary. In today's anesthesia practice, provision of neuroaxial anesthesia and analgesia is increasing, as I said earlier, along with the patient's fear of paralysis that accompanies placement of a needle near the spinal cord. Any subsequent nerve deficit is usually blamed on the neuroaxial block that has been provided. Knowing the side effects from labor, neuroaxial anesthesia, or both, is important, as anesthesiologists are the first consultants to evaluate whenever a complication arises in these patients. If there is a sensory or motor deficit in the lower extremities. Neuroaxial anesthesia may be associated with complaints of back pain, post-dural puncture headache, and severe complications such as hematoma or an abscess formation at the back. But most complications following neuroaxial blocks are associated with pregnancy and delivery, not the anesthetic itself. Signs and symptoms of the most common neurologic complications are described so that clinician can promptly diagnose and treat these patients and seek appropriate consultation. Even though the incidence of true neurologic complications arising from neuroaxial anesthesia is not known, they appear to be very rare. As anesthesiologists, providing care encompasses knowing the side effects and complications of the anesthetic we provide. Many of the nerve palsies that present in the post-operative patient may be of an obstetric origin, but anesthesiologists should be aware of anesthetic-related complication. Now, there was a scholar, a researcher, Wang, in 1979. He was the first to study intrathecal morphine using a 2 milligram dose that caused a high percentage of side effects. In the 35 years that elapsed since then, a large number of trials have been conducted and completed with varying and decreasing doses and for diverse situations. This experience provides the foundation to say that the currently used low doses of morphine, that is 50 to 150 microgram, there is no difference in the incidence of respiratory depression when comparing neuroaxial versus parenteral opioids. This statement is also made in the ASA guidelines on this topic. However, there is a group of patients that could be protected against respiratory depression as a result of the high levels of progesterone, a potent respiratory stimulant, and these are the obstetric patients. In obstetric patients, spinal or epidural anesthesia or analgesia should be accompanied with the administration of the well-established doses of morphine as a way to contribute to the solution of the post-operative pain affecting over 1/3 of the pregnant women. Presently or currently, the addition of opioids to bupivacaine, that's the local anesthetic for final anesthesia, has been shown to improve the quality of anesthesia by the action of fentanyl and extend post-operative analgesia by the effect of morphine. Side effects, particularly respiratory depression, have prevented their widespread use. Studies are not consistent regarding the incidence of respiratory depression due to the variety of definitions of this complication and the doses of opioids used. Low-dose regimens currently used do not produce further respiratory depression compared to the parenteral opioids. The high levels of progesterone, as I said earlier, a potent respiratory stimulant, makes safe the use of neuroaxial opioids in scenarios such as obstetrical anesthesia or analgesia. Hence, their use should not be overlooked. Neuroaxial techniques are currently used in obstetric anesthesia and anesthesia. These techniques have been modified as new anesthetic agents and adjuvants prove their superiority against their predecessors. The discovery of opioid receptors in the dorsal horn laminae in the 60s in the last century encouraged the study and administration of these drugs into the neuroaxis, a growing practice that represents one of the most effective measures in the treatment of pain, acute, obstetric, and post-surgical. The likelihood of respiratory depression frequently discourages the use of these drugs, although its incidence at the current doses is extremely low. The time of local anesthetic agent into the subarachnoid or epidural space is an invaluable opportunity to add morphine and fentanyl to the anesthetic solution, since the benefits of this practice during the postpartum, the transoperative, and the post-operative period are unquestionable. With the development of medical technology, the number of fetus and infant surgery have been increasing. In the early stage of life, whether exposure to general anesthetics impacts the long-term central nervous system adversely has become a global concern for medical professionals and the public. After years of research and observations, animal studies have confirmed that the application of anesthetics would cause neurodegenerative changes and abnormal learning abilities in brain development. Since 2000, 2017, the United States FDA has issued a warning about anesthetics and the developing brain, where the neurotoxicity of anesthetics has captured the more attention of the public. Advances in medicine have made it possible to perform more operations in the fetuses or newborn babies. This means that during the development stage of the brain, the rate of fetal anesthesia exposure rises. Although the application of sedation or general anesthesia is usually considered safe, recent studies in animals and children have evoked a problem. General anesthesia may lead to adverse effects on neurodevelopment. The main content of the FDA warning is that in late pregnancy or in children less than 3 years old, repeated or long time, more than 3 hours, use of general anesthetics or sedatives may affect the neurodevelopment. However, for other stages of brain development, the conclusion is not yet explicit. The neurotoxicity of anesthetics is influenced by drug toxicity, dosage, duration of anesthetic exposure, and the embryonic brain development stage. Genetic predisposition may play a role as well. The effects of general anesthesia on the developing brain remain a great concern in the medical field, and most researchers in this area focus on infancy and childhood. In recent years, with the continuous development of medical technology, the number of operations during pregnancy is increasing. However, studies on general anesthesia during pregnancy are relatively lacking. The mid-trimester of pregnancy is a critical period and is regarded as a safe period for surgery. But it is a fragile period for the development of the central nervous system and is particularly sensitive to the impact of environment. The general anesthesia may have adverse effects on fetal neurodevelopment during the mid-trimester, not the first and the last trimester. And for that matter, anesthesiologists should take this precaution to avoid drugs that cause teratogenicity or else cause adverse effects on the development of brain and neurobehavior. The FDA in 2016 issued a drug safety warning regarding general anesthesia and its use during pregnancy. In particular, the safety announcement required medication labels to describe the studies in young animals and pregnant animals that demonstrated an exposure to general anesthesia for more than 3 hours, which could cause effects on the developing brain and may have long-term effects on learning and behavior. In other words, women who require surgery during pregnancy must be advised of the potential risk to the newborn in regard to its effect on learning and behavior. In response to this warning, the American College of Obstetricians and Gynecologists, in conjunction with the American Society of Anesthesiologists, updated the committee opinion on non-obstetric surgery during pregnancy to include the statement, and here I quote, "There is no evidence that in utero, human exposure to anesthetic or sedative drugs has any effect on the developing fetal brain." This lack of studies in human changes with the publication. Potential exposure to general anesthesia in childhood, behavioral deficit. It was published in Anesthesia and Analgesia. Exposure to surgery and anesthesia in early childhood has been associated with an increased risk of behavioral deficits. Now, while the US FDA has warned against prenatal exposure to anesthetic drugs, but there is little evidence that exists to support this recommendation. The study they have forwarded evaluates the association between prenatal exposure to general anesthesia due to maternal procedures during pregnancy and neuropsychological and behavioral outcome scores at the age of 10. The prenatal exposure to general anesthetics is associated with increased externalizing behavioral problems in childhood. However, given the limitations of this study and that avoiding necessary surgery during pregnancy can have significant detrimental effects on the mother and the child, further studies are needed before changes to clinical practice are made. So there's no subtle and concrete, yet the dogma exists that the problems towards the brain may occur. When I was young, because I studied in Catholic schools, public schools, was in boarding house, and I developed a great taste for English literature. And my parents, although my mother was illiterate, but my father was highly qualified. And I started a bachelor course and got the top position in political science and English literature. And Phil Edmonds was the principal. And then my father forced me that you should go to medicine. Well, fathers in those days, they had their own will. Phil Edmonds said, well, don't take this student away from me. he will shine in this field. And perhaps he was right. Then what happened was that I went to the medical college, and there I also did well. And later on, I got specialization and then super specialization, then a fellowship and all that. But I have written innumerable articles which reflect that taste for English literature. So if I had not gone, I would have gone to become a political scientist or study international law, or perhaps become a writer. I wrote about the satanic verses, the dilemma of Hajj, and many articles besides medicine. And in anesthesiology itself, I achieved, with God's blessing, all those things which I should have achieved. I achieved everything. I was the best orator and a proclaimed speaker, an invited guest speaker in different international congresses, and was given many awards for the inventions and new methodologies that I presented. So I'm happy with it. I don't know if I had gone that way, the alternative route, would that have been better? Nobody knows.